Welcome to today's webinar. My name is Russ Rowan. I'm the Director of Marketing for Osteogenics. Before we get started, let me address how we'll be interacting today. From a technical perspective, we can't hear or see you, but we'd love to hear from you and be able to answer any questions that you may have. There's a Q&A button on the right-hand side of your screen where you can type your questions at any time, and we will get them answered during the webinar. At the end of the webinar, you will receive an email with a feedback survey. Once you complete that survey, an email with your CE certificate will be sent to you. So be on the lookout for that. It's my pleasure today to introduce Dr. Todd Scheyer. As a member of the dental team of Perio Health Professionals in Houston, Texas since 2001, Dr. Scheyer enhances smiles, improves wellness, and replaces missing teeth. Dr. Scheyer earned his bachelor's degree in biology with honors from Arizona State University. He then graduated magna cum laude and received several clinical research awards from the dental school at the Medical College of Virginia at Virginia Commonwealth University. Dr. Scheyer then went on to receive his certificate in periodontics and conscious sedation, along with his master's degree in biomedical science from the University of Texas Health Science Center in San Antonio, where he focused on perioprosthetic reconstruction and periodontal regeneration. Dr. Scheyer served on the board of trustees for the American Academy of Periodontology, is the past president of the Southwest Society of Periodontists and the Texas Society of Periodontists. Dr. Scheyer serves as a lecturer for the University of Texas Health Science Center at San Antonio and as a clinical assistant professor at the University of Texas Dental Branch in Houston. He has been involved with cancer fundraising and awareness for the past 10 years. It's a pleasure to have you, Dr. Scheyer. I'll turn it over to you.
Thanks, Russ. Appreciate it. I'll pull my screens up here. And yeah, it's a pleasure to be here with you all today and give kind of a little teaser from what I think is going to be a really exciting meeting in May with the first osteogenic soft tissue symposium. What I'm going to share with you today is really kind of a glimpse of the research we've done over the past 20 plus years, kind of our search for an alternative to the gold standard. However, we still realize that the gold standard is the gold standard for a reason, and many times that's what we rely on for optimal outcomes. When we talk about soft tissues where outcomes are super important, and they're based on type of attachment we develop that can create long-term stability. After all, most of the studies are too short to really give us the information we need for our patients and our practice to hopefully be in our practice for decades. So we use the evidence base to really help us determine what is the most appropriate graft material for our patients, and then what kind of stability we can achieve with these materials over the long term. It's been an evolutional process for sure, from doing a lot of the early efforts with acellular dermal matrix, and then to where we are today with the microdome material. It's been a very interesting ride, and a lot of this has been in the hierarchy of research, right? From basic case series to evaluate something and determine kind of the best way to study it at a higher level, all the way up to the systematic reviews that we rely on today to show us kind of how these newer materials compared to the evidence base that's out there, helping us all achieve what we really want, and that's regeneration, really a stable attachment to the root surface that's going to stand the battles of function and bruxism and microbial plaque. And in our practice, certainly what's been super important is getting some histological proof of principle that we can create regeneration, right? That we do have a healthy attachment to the root surface. So a lot of our research has been supported with human histological samples that show robust regeneration to a previously denuded root surface. Obviously we've done a lot of this with bone, with looking at bone grafts and the outcomes of vital bone that's developed when we're using bone grafts. That's pretty commonplace in the implant and bone grafting literature. Well, we're just taking that to the next level where we're taking human histological samples of teeth and looking at the root surface like this that has histological markers of, where the previous gingival margin was, the gingival margin and the bone position. And then after grafting, taking these human samples and being able to give proof of principle that regeneration has occurred. In this case, you see bone growth above the apical notch and a very healthy connective tissue attachment above the bone level all the way up to the CEJ, where there's then a long junctional epithelium from the CEJ up towards the periodontal sulcus. So it's this powerful proof of principle regenerative outcomes that help us really support what we're selecting for materials. And this is just taking a closer look at this human histological sample here in kind of the right between the apical and coronal notches that we put there. The inferior, the lower notch is the osseous crest. The superior was the old gingival margin. And when we look at this at high power, we're getting the constituents of true regeneration: new bone, new periodontal ligament, and new cementum. See new cementum even within that notch that's been regenerated during the healing process, and then going down towards the junction of old bone and new bone, well demarcated in the pinkish, right by OB. That's the junction of old bone and new bone. So we've been able to create new bone along a previously denuded root surface, and then a micro CT showing this in another view with hard and soft tissue coverage above the notches that were made when nothing was there. The McGuire Institute for Practice-Based Research was developed years ago by my partner, Dr. McGuire, and myself. Now it's branched out to 20-some centers across the United States, both periodontists and oral surgeons, taking clinicians that are in the trenches every day and doing high-level research that gives us a really good look at new innovations and new products. And it's this conduit for research that allows us to produce evidence to support new materials. Certainly, we understand the gold standard, both for root coverage on the top connective tissue and for developing a fungal zone of attached keratinized tissue, the free gingival graft. These are, well shown in the literature that they are the gold standard for a reason. And if that's your goal, you and your patient's goal, then very likely you're going to get the best outcomes with autogenous tissue when it comes to soft tissue. But there's something really important here, and that's called patient-reported outcomes. How does a patient perceive the outcome? Is it as important for them to get 100% root coverage, or would they rather have a slightly less result but more comfort during the healing process? So we're taking into account patient-reported outcomes when we do these clinical trials. The other thing that's important is when you look at the connective tissue studies we've been involved with, it's really hard to expect equivalence with alternative materials when the bar is set so high with autogenous tissue. When we look at all the studies and the controls of getting 97.2% root coverage, it's super hard to compete with that. So we have to keep that in mind, that almost equivalent is probably just fine when it comes to the patient's perception of the outcome versus the periodontist. This is a Bayesian plot of all those studies out there for outcomes, and kind of throwing us on there is for the subepithelial connective tissue graft, where we tend to sit above that mean for root coverage. So again, it's important to take that into consideration when we start looking at alternative therapies. And we look at this through an evidence-based alternative material selection. What is the strength of the evidence for these new materials? Is it real? Is it coming from, a setting where it's real, like real practice? And then how many studies out there have been done looking at the different factors? There's patient factors, both the local, the behavioral and systemic factors that we must address with our patients before we get started with this. There's certainly looking at the defects involved, single versus multiple, How deep is the recession to begin with? Is it in the mandible or maxilla? The phenotype. We know that phenotype makes a difference between the thick and the thin phenotypes, and how much keratinized tissue is present to begin with. That's a key factor when we're talking about gaining a functional zone of attached keratinized tissue. And the underlying bone support. Many of these recession defects have bony fenestrations as well. So we need to think about where these roots are in the alveolar housing, and are they beginning with a lack of buccal bone. In anatomy, there's all kinds of anatomical factors that we know about, looking at the tooth position, how deep is the vestibule, is there non-carious cervical lesions, previously restored root surface. These are things that we confront all the time, and they can be treated. It just has to be treated with the right techniques to achieve success with root coverage. In frenum pulse, we got to manage those as well during the process, either prior to or during these soft tissue procedures. Then there's surgical factors. There's experience out there. I mean, we need to consider, who's doing the surgery, how long have they been doing this, what is their training. That's important, is certainly when we're picking up new materials for the first time. If they don't have a ton of experience with just the management of flaps and incisions and suturing, they may not be the best person beginning using alternative materials until they've mastered the gold standard. Treatment strategies, there's all kinds of them, right? So I think this too is the water is getting a little bit more murky out there, because there's many different techniques to achieve root coverage today. And it has to be something, one, you look at the evidence base, and do we have good clinical trials comparing one technique to the other? And two, what is your comfort level, the individual surgeon's comfort level with the alternative techniques? And materials, that's what we're going to talk about today, is, what are the materials that we feel are giving us a good chance to get near to the equivalence of the gold standard. Combining all these, like the evidence base that's out there, the patient defect and surgical factors, and then this very important concept of patient-reported outcomes, will give us this optimal treatment that also is making the patient happy. So that patient-reported outcomes are something that the FDA has implemented into clinical research now. They're important to include patient-reported outcomes in our clinical trials. What the patient sees and perceives is very important, and we're happy to have published one of the first papers on patient-reported outcomes in perio back around 2009, 2010, and this has set up a template for success for researchers out there utilizing patient-reported outcomes and getting accurate measures of those. It's a very challenging thing to do. We work with behavioral scientists to do this, and it's challenging to tease out that data, but it certainly does matter when it comes to small differences in outcomes. What the patient perceives is super important to the materials we select. So again, combining all these, hopefully we're going to come up with the best treatment for that individual patient. And we'll start with how the clinical trials we've done. 6-month studies were pretty common when a new material comes along. What we've done is to make sure that in the original protocol, we write towards long-term outcomes of 5, 10, and even 20-year outcomes. This is really strong data when we can take follow-up from 20 years and bring it back to other clinicians and say, hey, not only did we study it early on, but we followed these patients for a long time to see how the outcomes held up over time. And this is something that can be done in the private practice setting. It's super hard to do in an institution, but in the private practice setting, a lot of these patients are patients for life. They're on our recall system, so we can bring them back and get this data that's so important to clinicians to make decisions. A couple of these studies that have long-term follow-up for root coverage, the xenogenic collagen matrix compared to the gold standard. This is the 1-year results of 100% root coverage for both the connective tissue and the alternative. Percent root coverage, the gold standard wins, but the results for the collagen material were respectable. When you look at the literature base out there, these getting 83 to 88% root coverage is very good. And then this same study looking out past 5 years, it held up really well over time, where we're seeing the root coverage maintained over a 5-year period. And then comparing our study to a European study, respectable results for the coronally advanced flap versus connective tissue, but connective tissue tends to win the battle on root coverage. And the connective tissue also, as you see to the far right, the 6-month versus 5-year, or 6-month versus 3 years, we're getting good stability over time. And there's not a clinical significance between baseline and 5 years for each modality. So looking at this similar collagen matrix for a non-root coverage, this is very much an acid test where we're leaving it open and exposed to the oral cavity, and we're really just trying to build a functional zone of attachment and not gain any root coverage. The width of keratinized tissue developed was pretty equal for the free gingival graft. What we put there, we end up getting after 6 months, whereas on the test site, we're using a collagen matrix that enabled us to generate almost 3 millimeters of keratinized tissue with no autogenous tissue. And the patient preferred that non-palatal donor site, which would be obvious, right? If we can avoid that palatal donor site, this is a huge plus for us as clinicians and for our patients. So we have 6 to 8 year data on that. Looking at these defects now, 23 of the original 30 patients were recalled. And you can see over 5 years, good stability of the tissue grafts, both for test and control, maintaining that over 4 millimeters of KT for the test or for the control, and almost 3 millimeters for or at 3 millimeters at 5 years for the test, the collagen matrix. The other thing that's interesting here is we've oftentimes see with autogenous tissue some increase over time. It can happen. This creeping attachment or increase in keratinized tissue we've seen multiple times in our research. So if the major goal is to prevent further recession, this study clearly showed that we were capable of doing that recession numbers did not increase over a 5-year period after the grafting, whether it was the test or controlled. But 80% of the patients preferred the test. 80% of the patients preferred the collagen substitute. Another material, kind of a bigger volume material used for root coverage here, both around teeth and implants. This is where we're introducing the digital technology for measurements. So going from the classic measures that we would do for hard and soft tissue using periodontal probes and bone sounding, getting more sophisticated with the research, utilizing digital scans, both pre and post-operatively, to measure our outcomes. The conclusion was that connective tissue gave us a more stable root coverage, but the volume was also maintained by about 2/3 of the original, meaning immediately post-operatively you have a significant volume change with the test material, and this shrinks down over time. But once it gets down to this approximately 2/3 of the original, it stays stable. The connective tissue did win as far as percent root coverage, but we were able to achieve very good root coverage numbers with the collagen matrix. And the same thing was done around implants, volumetric changes around dental implants, using the digital technology to evaluate the volume changes and good stability over time. And the technology really is a game changer when we start looking at future studies for volumetric changes around teeth and implants. Soft tissue augmentation, thickness, volume gains using 3D scanning provides measurement actually beyond the eyes, able to discriminate. So this is just a higher level of analytics when it comes to clinical research. The technology will require a more thorough investigation of what constitutes the clinical effectiveness margin. So it's really awesome stuff to have this technology at our in our hands, but we're going to have to look at things a little differently because of the accuracy of which we're measuring now comparatively to classic measures performed with the periodontal probe. But between the pros, we were able to determine that around dental implants that we got a non-inferiority result, where the results were good with the alternative, and most importantly, patient preference was typically with the non-palatal donor site. Adding these studies all together, both the collagen matrices and other studies done with growth factors, we've been comparing our results to the far right, which is the systematic reviews on averages, and connective tissue still winning that battle, as well as enamel matrix derivative with a coronally advanced flap. And you see the acellular dermal matrix being kind of the loser of this group. So how can we change that? What's next as far as our ability to improve outcomes with acellular dermal matrix? But the good thing with all these studies is that it is, with the long-term data, we're seeing stable results over time. And as I mentioned, Mike and myself and our team have done a lot of this. These are a list of studies we've done for just increasing keratinized tissue, and then a bigger laundry list of studies looking at alternatives to connective tissue for root coverage. So we've had a lot of experience with this. We continue to stay on this quest for something better, and this is our foray into looking at an alternative type of allograft for both non-root coverage and root coverage. So our pilot study done a few years ago now, and submitted for publication under review right now, is looking at this this new type of acellular dermal matrix. It's been striated and opened up, so to say, to allow for what we think is early vascularity. If you look at the right and left here, you can see the microsurfaced alloderm on the right and the non-surfaced on the left, and there's a significant absorption of the patient's blood immediately when we use the microsurfaced material. So here you see the outcome of the test site here at the day of surgery, and this material is very nice to handle, easy to suture with non-resorbable or resorbable sutures. And then you see the early healing on the right. We'll look at this case a little bit closer in a minute, but this is what I'm talking about as far as the absorption of the tissues of the patient's blood to get us onto a good start with wound healing. So one of the most common things we confront in perio is this lack of attached keratinized tissue around teeth, which leads patients to have gingival recession. We love the idea of allografts. They're very commonly used in bone grafts. So we're gonna look at the acellular dermal matrix and specifically compare a microsurfaced ADM to what's been considered the gold standard out there is the non-microsurfaced alloderm. It's a pilot study, prospective, randomized, within subject control with 10 patients, which completed the study. The objective of this trial to evaluate the clinical healing outcomes of the microsurfaced ADM to augment areas where there's insufficient attached gingiva, and comparing this to the traditional acellular dermal matrix out to 6 months. Okay, it has been suggested, if you look at the literature out here, that the processing methods of ADM could affect outcomes. So from this publication in 2021, they felt that there's no doubt that the outcome of gingival phenotype modification therapy largely depends on the properties of the utilized grafts. So if we're going to have those outcomes, we have to look deeper on, what is the true characteristics of the graft and how is this going to be leveraged during the surgical approach we take. Here's looking at case one. If you just panel this from, pre-surgery out to 90 days here, you're seeing, what looks like a really avascular graft in the top panel. Now, certainly, we know that the wound healing is happening underneath this graft, so it still is going to allow for good keratinization and gaining a tissue band after healing. But when you look at the bottom panel, it's quite different, right? There's a vascularization of the material, and we're not seeing as an obvious of a slough of the superficial portion of the graft. With at 90 days to the far right, we've been successful with creating a functional zone of attached gingiva. The conclusion from the cases in this study, when we looked at comparing side by side in the same patient, we had faster healing and earlier integration with the surrounding mucogingival tissues with the microsurface material. More of the 20% of the non-microsurfaced became displaced. And then over 180 days, the level of KT and clinical attachment levels were significantly improved by both treatments. So both treatments allowed for successful outcomes. And we could not note significant scarring from these techniques, which is favorable because we definitely see delineation of scarring when we use the free gingival graft. But the bottom line is both grafts were effective to accomplish our goals here, and we need a bigger study really to really quantify this and power it appropriately to look at this at a closer level. We need more clinical research. But certainly from the clinician's perspective, when you look at these two panels of wound healing, one looks much kinder than the other, and that matters to the patients when we're talking about baseline of this patient here, the non-microsurfaced on the left and the microsurfaced on the right, and then here we are at 2 weeks. Just a big difference between one and the other. And again, I don't think a lot of clinicians utilize this approach in their day-to-day practice, but from a clinical research perspective, if you want to perform an acid test, this is it. If you really want to test something, this type of procedure is a very harsh test of the material. And even with the sloughing on the left side, you still have a nice outcome when we get out to the 6-month period. In a close-up of the micro surfaced side, a very nice, healthy, functional zone of attached gingiva that's well keratinized, and even the gingival stippling has come back with maturation. So we can feel really good about that, resisting the future recession for this patient. And histologically, we took histological samples showing that we have normal outcomes in the healing. There's not a lot of inflammation. This is normal soft tissue that's healed over time, over a 6-month period. Now looking at a case of using the microsurfaced ADM versus the traditional in the root coverage model. Side by side, here's the two defects. The right side is going to be getting the microsurfaced material, taking both vertical and horizontal measures, doing root planing with hand instrumentation, treating the root surface with either citric acid or EDTA. Pick your choice here to detoxify the root surface, especially when these root surfaces have been previously restored. Here you see the traditional material, and now taking a close look at the microsurface material. Hard to depict in this, but there's these microstriations And you see just the absorption of blood when it gets put into the wound. Easy to suture here with resorbable sutures to stabilize the graft material, and then Prolene sutures to advance the flap. And, not uncommon to see some wound dehiscences with the traditional material. We think because of its challenging with the challenges of making it vascularized, we're getting a little bit of sloughing on the distal margin with the traditional approach, and no sloughing on the side with the microsurfaced. And now out to 30 days, that little early slough affected 100% root coverage. We got 100% on the right side, but not on the left. Certainly volume-wise, we've got excellent volume changes. And here's my first case at 9 months, both with the intraoral scan pictures on the top and then clinical photography on the bottom. Here's looking at a combo case of doing soft tissue work at the time of implant placement. This is her right side that she never wanted to do this again. I'd done a free gingival graft for her many years ago, and she really resisted getting the left side treated. This worked really well for her. We got a very nice zone of attached keratinized tissue, but she did not do well as far as the palatal donor site. So when I mentioned to her that we could consider managing her recession on the bicuspid and molar here with an allograft, she was very excited. We're using guided surgery there to place the implant in the 18 site, and then using the microdome material with enamel matrix derivative in this case. On the far left, you can see those striations quite well here. And we're getting this little biologic root reshaping as well to get rid of the cemento enamel projection. And you can appreciate the abfraction on these teeth in the upper left. We eliminate those with finishing burrs to create a very compatible root surface to graft against. And then root coverage, advancing the flaps in the lower right there. Here we are at 7 days, seeing really nice healing. Right and left side paneled at 7 days. And I'll have longer term follow-up of that case. We just uncovered the implant last week, so we'll have that in Phoenix to look at that. Here's a case of Sean Rottenberg, who's done a lot of work with this material on abfraction lesions and even previously restored. This is an advancement of the flap. And you can see 2 weeks, 5 months, and then 1 year, having a nice result regarding root coverage as well as tissue tone, texture, and volume. Another mandibular case. Look at the process of root surface biomodification, placing enamel matrix derivative, the microdome material, and then advancing the flap, and then seeing it at 2 weeks, 4 weeks, 4 months, in 1 year. We have had some recurrent recession, but overall a nice result and a thicker gingiva to hold up over time. And looking at this, again, this is what I think the difference is between the microdome material and the classic acellular dermal matrix, is this ability to allow fluids to enter the material. This could be the patient's blood, also could be growth factors. We know growth factors bind to collagens, so it's a perfect material to carry growth factors with biological principles. And in using these for this evidence-based approach, we really just need some more data. I feel that now we've gotten a lot of clinical experience level with it, and it's time to really put it to the test with a larger sample of patients to add to the evidence base out there for material selection. Taking all these things into consideration, as well as what the patient thinks, to give us this outcome for the best treatment for our patients. I also want to mention that we are currently providing education in Houston that will provide courses like soft tissue courses, looking at materials like microderm to get patients' hands wet before they bring it back to their practice. Our next course will be both hard and soft tissue and an implant fellowship coming up in April, May, and June. It's 3 weekends that we'd love for you all to join us and get some hands-on experience. I think one really unique thing about our learning center is we utilize fresh cadavers that are outstanding specimens to work on versus the classic use of pig jaws or other animals. The cadaver certification has been a game changer for our students that want to get their hands wet with new materials or new innovations. So thank you guys for your attention, and sure hope to see you in Arizona here in just in a few months.
Thanks, Dr. Scheyer. Appreciate the insight. Fantastic presentation. Beautiful pictures. So always appreciate your insight on this topic. We do have a few questions here. First, I'll start off with, are there any non-negotiable factors or just, I guess, deal killers when it comes to I think the question really stems to, are there situations, clinically whenever a patient presents that might make you not make an alternative to autogenous an option?
We try to limit it when there's no keratinized tissue. So we'd like to see 1 to 2 millimeters of keratinized tissue to begin with. We've had some significant wound healing issues when there's no keratinized tissue. So that would be one thing that would stand out. But other than that, no, there's other systemic issues you have to manage, whether it's an allograft or autogenous tissue. So those are the same, whether it's one or the other. But the main thing when we use alternatives is if we don't have a little bit of a band of keratinized tissue, we tend to see more wound healing issues when we don't have it.
Great. Have a couple questions around the use of growth factors, specifically EDM, which you showed. Is it something that you always use? Is there specific factors that would make you use it when maybe you wouldn't use it? What's kind of the decision tree there as far as growth factors?
Yeah, we routinely use them, whether it's a recombinant platelet-derived growth factor or an enamel matrix derivative. These are commonly used. And the reason for it is that when we did the histological studies with those two growth factors, we achieved regeneration with them, and we clearly did not achieve regeneration without them, right? So we had proof of principle with multiple specimens showing us that the biological influence of growth factors is real, that it does influence the type of attachment to the root surface. So this is important to us. We just, sound biological principles. If we can recreate periodontal ligament, new cementum, and new bone versus just having a connective tissue attachment, we believe this can affect the long-term stability of these grafts.
Great. You being a private practice, but also doing a lot of clinical research, what's a reasonable time frame to look at when we're discussing long-term results?
So your question is, what would be considered a long-term result?
Sure.
Yeah.
Sure.
3 to 5 years.
Okay.
I think that 6 months to a year are not long-term. They're good. It's great to have that 1-year data and get that idea or topic into the literature with that. But as a clinician, I want to see how it's looking at 5+ years. We know from the acellular dermal matrix literature that it tends to decline after 5 years. So we want to know that, right? We want to have that knowledge so that we can talk to our patients that, we can maybe get you a nice result in 6 months to a year, but this could decline after 5. You know, your patients want to know that, right? That may be the reason they select autogenous tissue, is that they don't want to plan on doing this again in their lifetime, and they'll accept the palatal donor site to get a result that's going to be more stable over time.
Makes sense. What is your preferred type of your preferred, I guess, flap type, flap incision? Is there a difference in outcome with when you're using these ADMs based on split thickness or full thickness flaps?
We're usually using split thickness. And so in the research, it's a great question because it also points out something that you'll see in our presentations. Oftentimes you'll see a classic vertical incision coronally advanced flap, because that's in the literature, that's what was commonly used, the Langer approach to root coverage. In our day-to-day private practice, it's customized per patient. Sometimes there'll be no vertical releasing and just a tunneling approach. Sometimes there'll be one vertical on the distal, so we can hide that vertical in the posterior region. And then there's still times where we need 2 vertical releasing incisions, but those are customized per patient and per situation. So we use the microdome material with a myriad of different approaches. I love using it though through a tunneling approach. It's just a very atraumatic way to do this, and you know, if we can avoid cutting through papilla or creating verticals and not violate the blood supply, then we're going to have better blood supply to the allograft. So anytime we can do that, we do, but there are limitations.
Understood. You spoke to this, but you can probably even clear it up further. But based on your study, would you now consider microderm as an option for how would you
Breaking up there, Russ? I didn't catch all of that.
compare the data that you've seen and the cases you've seen with used in I think it gets to, you know, normally we talk about the microderm being used as an alternative to a CTG and CG, but understanding that when you guys performed your study, it was used more as a GG alternative. So can you just talk a little bit about your experience there?
I'm not sure I caught all that. We have used it in both, right? We've used it
leaving the microderm exposed.
Leaving it, yeah. So leaving it exposed was the free gingival pilot study we did, and it as far as its early wound healing, it was improved better wound healing than the non microtextured acellular dermal matrix. That was very clear. But at 6 months, the outcomes were very similar. So it then came down to patient-reported outcomes. The patients that we used the microderm on had less pain, for sure. So they had kinder healing, visually better healing. So that really mattered a lot to the patient. So I think it's critical that even though the results could be near equivalent when it comes to classic outcome variables like gain in KT, clinical attachment level, you know, the quantity and quality of the tissue, that's certainly important for a periodontist, but we need to pick up on the patient-reported outcomes too to see which one wins there, because that matters too. And clearly, the winner was the microderm when left exposed.
In those cases, did you have any? Do you have, from your previous experience with the xenograft collagen matrix left exposed, any obvious differences in the way those sites healed?
That's a hard comparison to make, given that they were completely separate studies. But I would say that the healing of the collagen matrix was very close to that of microderm, right? So the collagen matrices, they do a wonderful job of absorbing the patient's blood. So you have that early nutrients supplied to the graft with both the microderm and collagen matrices, which we don't get with traditional acellular dermal matrix. So I think that I would have to say that I would think that the wound healing is very similar between collagen matrix and the microderm product.
Great. Okay. Maybe one or two more. How do you deal with situations in which you cannot chronally reposition a flap sufficiently to cover a soft tissue graft, or basically an autogenous graft, or an alternative to autogenous?
Well, I mean, certainly you want to develop techniques to be able to cover it. So I think that most of the time you can, if you know how to do good releasing, you can get it to cover. But in times you don't, for root coverage, I'm wanting to have connective tissue there with a growth factor. I'm not going to be as confident leaving the microderm exposed as I am connective tissue, because we've seen so many case examples over time where leaving connective tissue slightly exposed doesn't seem to make a difference, whereas leaving a allograft exposed does. We tend to lose that aspect of the allograft that's left exposed up on the root surface. If you're leaving the allograft exposed in a free gingival graft application, that graft's all down on periosteum. It's not up on the root surface. If it was, it wouldn't survive. So putting these grafts up on a root surface exposed is just not a good idea.
Great. Last question. Any experience or commentary about using PRP or PRF in these soft tissue grafting procedures?
We use PRF for facial aesthetic procedures now. We use it for bone graft handling characteristics. But based on the science that we've seen and have contributed to, I'm going to pick up recombinant platelet-derived growth factor before I spin patients' blood today, because you really don't know what you're getting when it comes to the patients where you really need it. Well, their platelets aren't too great. So I'd rather pick something off the shelf that's going to have consistency and concentration of the factor that we need, very predictably.
Sure. Great. Well, we will wrap it up there. Dr. Scheyer, once again, appreciate you taking the time to present today. And for everybody that's out there, just want to make sure a couple last final thoughts, I guess, would be Dr. Scheyer mentioned it, but we have our first annual soft tissue grafting symposium coming up May 1st, 2nd, and 3rd in Phoenix, Arizona. We have a fantastic lineup of speakers, with Dr. Scheyer being one of them. We would love to have everybody that's in attendance the call today join us. So you can find information at osteogenics.com if you want to register for that event. Also, as I mentioned in the introduction, you'll be getting an email with a survey shortly after this webinar. And once you fill that survey out and submit it, you will get your CE certificate. So please be on the lookout for that. And with that, we will say goodbye. Thanks again, Dr. Scheyer.
You're welcome. Have a good day, everybody.